Hello and welcome to the Gustavo Franco podcast, where we explore the multifaceted world of healthcare. I'm your host, Gustavo Franco, a passionate healthcare student and an aspiring physician. Our mission is to better understand the U.S. healthcare system while studying both its flaws and strengths, as well as comparing it to other healthcare systems around the globe. Not only do we examine the policies and regulations behind healthcare, but we also take a closer look at the experiences of patients and doctors within the system. We aim to provide listeners with a deeper understanding of how healthcare truly operates. We share stories of individuals navigating the U.S. healthcare system, as well as present engaging interviews with professionals offering their experiences and expertise to help us understand the inner workings of healthcare. We believe that an informed public is the key to creating a more effective healthcare system, and we dedicate ourselves to this mission, providing insight and analysis on the ever-changing landscape of the U.S. healthcare system. Join us every month as we embark on a journey of studying healthcare together. Please note that the opinions expressed on this podcast are ours and of our guests and do not constitute any professional advice. While we strive to be as accurate as possible, we acknowledge that there are often many viewpoints on a topic, and our research may not be exhaustive. Therefore, we encourage listeners to engage with the subject matter and conduct their own research and confirm any information before making any decisions. Thank you for listening and joining us on this healthcare exploration. In this month's episode, we will be discussing Medicaid, and this is actually a topic that I would like to discuss over 2 episodes. They can both be listened to independently, but in this episode, I'll explain Medicaid, and in the next episode, I'll be joined by someone that is currently on Medicaid to share their experiences and also talk about all of the current events related to Medicaid. My goal here is to help everyone understand all of these current events happening in regards to Medicaid, and I'm sure you've heard a lot about them as we near the potential debt crisis last month. So, in this episode, I'll be introducing Medicaid and explaining everything about it. We'll dive into a brief history of the healthcare system prior to Medicaid. We'll talk about how and why Medicaid was created, how it evolved over the years, and what it looks like right now. But to start off, I just want to make clear the distinction between Medicaid and Medicare because many people often confuse the two. Last week, actually, I had one of my friends talk to me about Medicaid, but I actually mean Medicare. So I just want to share an easy way that I use to differentiate between the two. These are both programs created under the Social Security Amendments of 1965, but there's a key distinction between them. Medicare is a health program at the federal level for people over the age of 65 or with very debilitating health conditions such as end-stage renal disease. Medicaid, on the other hand, operates as a joint federal and state program offering health insurance for those with limited income. So how do you remember the two, right? There's a little trick that I like to use, and I like to think of it as Medicaid. Aid. Who needs the most financial aid? Those with limited income. Whereas Medicare. Care. Who needs the most care? Senior citizens or those with very debilitating health conditions. So there you go. That's my little trick. Now let's dive right into the episode. Enjoy. So, to understand what led up to the creation of Medicaid, we should first examine the healthcare system that existed before Medicaid came about. So, we're going to look at the healthcare system and what it looked like before Medicaid, who the major players in health insurance were, and what the major drivers that brought about Medicaid were. To start off, the landscape of healthcare in the United States before Medicaid was quite different, and we won't dive into too much detail of this history of health insurance, because that kind of deserves an episode of its own, but I'll go into a brief history of it here. And one thing from healthcare history that we'll first have to conceptualize to understand why Medicaid came about is the progression of healthcare cost, which happened as medicine evolved, of course. I think many of us forget that healthcare has existed since forever, but not in the form that we see today. What you see in the movies is kind of true. People used to brew plants and go into people's houses and do rituals that they thought were going to help cure diseases. And in turn for these potions they would brew, patients would bargain other items such as bread for them, right? Then we began to have a slightly better service of professionals that went into patients' houses to treat them, even if there was no scientific backing to that. To keep on the movie example, I'm sure you guys have seen the movies of Friends in the 1500s where doctors would go into patients' houses and do God knows what to them. Of course, that might be a little exaggeration, but most of what they did at that time was not scientifically backed yet. My point here is that healthcare services have always existed, and it literally went from people brewing random potions to what we have right now. And it was in the late 1800s going into the 1900s that healthcare services really boomed like the Industrial Revolution did, and hospitals with proper care began to be established. But one key thing is that as healthcare quality improved, so did its price. But it doesn't end there, because medical treatment has been improving and also becoming exponentially more expensive as we began to focus on treating chronic and late-stage conditions. It's crazy to think of something that people used to barter for with goods now accounts for 19% of the annual GDP. Everything related to healthcare has been increasing in price. Pharmaceuticals began to increase in price to pay off all the research and trials that they ran through and failed. Advancements in medical technology brought about new machines and scanners that cost unimaginable amounts of money now. Healthcare provider salaries are known to be extremely high salaries, and who pays for that? The consumer of healthcare. The prevalence of chronic diseases and the introduction of expensive diagnostics and therapies only made this worse, because our inefficient and fragmented healthcare system, along with insurance complexities, also added to the financial burden. Demographic challenges like the aging population and also like lifestyle factors played a major role. These all deserve an episode of their own, but it's just a brief aside of why how healthcare costs are increasing, and that also meant that more and more people lacked access over time. And this really became a problem in the U.S. as the population became more and more stratified with significant wage inequalities. And I'm sure this is something that you've talked about in your history classes. So access to healthcare was primarily dependent on private insurance coverage and the ability to pay out of pocket. But this all became harder and harder, and it meant that individuals and families with limited financial means often faced significant barriers to receiving necessary medical care. So as healthcare prices skyrocketed, it was clear who could and who couldn't afford health insurance. But even if you couldn't afford private health insurance, there were other ways that people were getting insurance in the 1900s. So let's look at what the health insurance market looked like before Medicare and Medicaid. One of the major sources of coverage was employer-based health insurance. Many Americans relied on this type of coverage, which was typically offered as a benefit by large employers and some smaller companies. Manufacturing companies and large corporations were the ones that played a significant role in providing healthcare coverage to their employees, because some smaller companies kind of shied away from it because it could mean that if a lot of their employees got sick, their premiums would go up and the company would have to pay a lot more. So another significant presence in the private healthcare insurance landscape was commercial health insurance companies like the ones that we already have today. Companies like Blue Cross Blue Shield, Aetna, Cigna, and United Healthcare were among the major players already. They offered a range of plans including individual, family, and group plans that were often purchased by the employers. These insurers also catered to individual families and groups outside of the employer-based system. So in addition to the employer-sponsored and commercial health insurance, there were also voluntary health insurance associations. These were usually nonprofit organizations that provided coverage to a specific group, such as teachers, government employees, and other individuals affiliated with certain professions. Here are a few examples. There was the American Medical Association, the AMA, which offered coverage to physicians, while the American Bar Association, the ABA, provided coverage to lawyers, and the VHA, which still exists and has a big presence in our society, offered coverage to veterans. However, it's important to note that private health insurance before Medicaid had its own limitations. Coverage was often costly and came with many restrictions. Pre-existing conditions were commonly excluded from coverage, making it challenging for individuals with chronic illnesses or certain medical histories to obtain insurance. They did not have many of the ethical regulations that we now have, and people with serious conditions were many times left without insurance. Many private insurance plans also had very high deductibles, copays, and exclusions, resulting in significant out-of-pocket costs for policyholders. Access to private health insurance was not universal, and many disparities existed. While it's estimated that about 70 to 80% of the population had some form of private health insurance, many individuals, particularly those in low income or vulnerable populations, were uninsured or had limited access to affordable health care. And even for those that had the health insurance, it was hard for them to get access to quality care for all their needs because of the very high out-of-pocket payments that we talked about. And this really created a gap in healthcare access and affordability that we'll talk about now. So, as this issue of inadequate healthcare coverage gained increasing attention, policymakers finally recognized the urgent need to address them. The civil rights movement and the broader push for social justice only added to this and really highlighted the disparities in healthcare among different socioeconomic groups. Picture this, right? It's the 1960s, a time of change and transformation in American society. We have all these social rights activist movements, and the nation moved forward, and it became increasingly clear that not everyone had access to the healthcare they needed. Gaps in coverage left many vulnerable individuals and families struggling to afford essential medical services. Something had to be done, and people knew about it and were distraught about it. And that's where Medicaid enters the stage. So to summarize what we've talked about here, the main issue leading up to the creation of Medicaid was the following. There was a pressing need to address the millions of low-income individuals and families who couldn't afford private health insurance. These were hardworking people who found themselves caught in a web of limited health resources and inadequate access to health care. They were left to navigate a complex maze of medical bills and impossible choices as the prices of health care continued to rise, and so did the income gap. And not to add, the ever-increasing costs of healthcare and the growing demand for healthcare services really strained the system and made it even harder for those with low incomes to get care without premium health insurances because hospitals wouldn't want to take them. So if demand kept increasing and price also kept increasing, it was clear that if it weren't for a policy like that of Medicare, Medicaid, the health insurance gap would keep getting worse and worse. So it was against this backdrop that Medicaid emerged as a beacon of hope. The program, established under the Social Security Amendments of 1965 under President Lyndon B. Johnson, was Medicare and Medicaid. Medicaid was specifically designed to provide health coverage for low-income individuals and families who fell through the cracks of the private health insurance system that we just talked about. However, before we dive into what the Medicaid program actually looked like, the Social Security Amendments of 1965 was not the first attempt at mitigating these disparities in healthcare access. Before the creation of Medicaid, several healthcare policies had already been implemented with the aim of expanding coverage and addressing the gaps in healthcare access that we explored. While these policies made significant strides, they still fell short of addressing the root cause of the issue and providing comprehensive and accessible coverage for all Americans. So let's explore a little more of these initiatives. One notable policy that preceded Medicaid was the Kerr-Mills Act of 1960, also known as the Medical Assistance for the Aged program. So, as you can see, it's more of like a Medicare type program, but it's still very relevant. This program provided federal funding to states to assist elderly individuals with limited financial means. And it was kind of a joint state and federal program that acted similarly to Medicaid, but was targeted at the elderly population. But while the Kerr-Mills Act was a step towards addressing the healthcare needs of the elderly, it was limited in scope and did not provide comprehensive health coverage. Another significant healthcare policy was the Hill-Burton Act of 1946. This legislation aimed to improve the availability of healthcare facilities and services, particularly in underserved areas, targeting the populations that we talked about earlier, right? And under the Hill-Burton program, federal funds were allocated to support the construction of and modernization of hospitals and other healthcare facilities, especially in those underserved communities. And in return, these facilities were required to provide a certain amount of free and reduced cost care to individuals who couldn't afford and pay for services. The Hill-Burton Act played a crucial role in expanding access to healthcare infrastructure in many communities, but it focused primarily on facility development and did not directly address the issue of healthcare coverage for individuals who couldn't afford private insurance. Another program that happened during the Great Depression was the Social Security Act of 1935, and this is an important one because it established the foundation for social welfare programs in the U.S. And while the Social Security Act did not provide a comprehensive health coverage, it laid out the groundwork for all future initiatives like Medicaid. And prior to the implementation of Medicaid, some states kind of experimented with their own programs to expand healthcare coverage. For example, in 1961, the state of California introduced the California Medical Assistance Program, called CMAP, and CMAP aimed to provide healthcare coverage to low-income individuals and families who weren't eligible for other government programs. This state-level initiative served as a precursor to the broader national Medicaid program that we're talking about. But despite these efforts, the fragmented nature of these policies and programs meant that many individuals and families remained without adequate healthcare coverage. So the root problem was still a problem throughout the entire U.S. And these policies tried to tackle a very specific issue and failed to fix this root problem. The need for a more comprehensive and coordinated approach became increasingly evident, and policymakers realized that. And the creation of Medicaid as part of the Social Security Amendments of 1965 was a significant milestone in expanding coverage to low-income individuals and kind of was, as I said earlier, the beacon of hope, and it fixed all these problems that other policies couldn't fix. Medicaid represented a federal and state partnership that aimed to provide a safety net for vulnerable populations and reduce disparities in healthcare access. Over time, Medicaid has undergone many expansions and modifications to increase healthcare coverage, but this is something that we're going to discuss later on. Let's turn our focus back to the creation of Medicaid and the Social Security Amendments of 1965. Medicaid's goals extended beyond mere coverage. It aimed to improve health outcomes for the most vulnerable populations by providing access to preventative care, screenings, and early interventions. Medicaid wanted to catch health issues before they escalated, promoting healthier lives and reducing the burden of emergency rooms. And this is all of the history behind Medicaid and the creation of the program. So now that we've laid the groundwork to understand everything, we'll talk about what Medicaid actually looks like right now. So let's dive right into that. And even though the creation of Medicaid was very promising, and so is the coverage that we now see with 1 in 5 people in the U.S. being in Medicaid, we also have to consider some of the drawbacks of it. So that's kind of what I want to start with, because we've talked about all the benefits of Medicaid and why it came in and why it was so important. But now let's talk a little bit about the drawbacks of it, right? So Medicaid participants now have the freedom of choice in that they can go to any doctors they want. But there's a catch, right? The doctor must be willing to accept Medicaid insurance. And in the U.S., only about 70% of physicians accept Medicaid, and this varies greatly by state, with states like New Jersey only having about 40% of physicians accept Medicaid. But the disadvantage doesn't end there, because even though around 70% of physicians accept Medicaid, many of those are less likely to accept new patients that are on Medicaid. But why is that, right? The answer lies mostly in reimbursement rates. Physicians get paid a lot less for Medicaid beneficiaries, and practices that accept Medicaid usually tend to make less profit. Additionally, physicians have a lot more paperwork to do for Medicaid patients, which makes them less likely to accept new Medicaid patients. And some of you might still be saying, right, 70% accepting Medicaid is still pretty good, but that also doesn't mean that physicians can't still be more reluctant to accept new patients, as we just talked about, because they will get lower reimbursement rates. And this can be a problem, especially nowadays, that physicians are always booked and it's hard to find one that's taking new patients. Let me give you an example of myself. And keep in mind that this was done with me, and I have Cigna, a private health insurance. So everything that I'll say would likely be harder for someone in Medicaid. So a couple of months ago, I called to schedule a primary care visit at the hospital chain near Georgetown that I go to, and they said that they only had appointment for new patients 4 months from then. So I was like, never mind. I don't want to wait. And then I just ended up going to the student health center that they have on campus and getting my general checkup there. Then earlier last month, I decided that I wanted to schedule an appointment to get a new primary care physician since I don't have one right now. So I called the hospital again. And this time they told me that all attending physicians were not accepting new patients, but that I could get an appointment with a second-year resident 2 months from now. So I said, sure, that's great. Works for me, right? It'll be someone closer to my age, and this time it won't take 4 months. So I was happy about it, but I can also see how many people wouldn't love that. What if they wanted to see a doctor sooner? it's pretty clear that even with private health insurance, accessing quality care is already difficult in this world. So just imagine how much harder that is for people in Medicaid. And to be honest, that's not the only limitation. I still haven't gone into the prescriptions and out-of-pocket expenses. It's pretty convenient because last weekend I was flying home and this woman sat next to me and we started talking about health insurance, and she told me that she had been both on Medicaid and Medicare, and she was writing this book, right? And I was talking to her and she mentioned that she had this condition called Hirschsprung disease. I don't know if I'm pronouncing that right, but bottom line is that it was something that affected her colon, and she had a surgery to remove it, and so she had a colostomy bag. And for those of you who don't know what that is, it's a bag that stays outside of your body and connects to your intestines so that you can pass stool to the bag. Okay, so getting into how this actually relates to Medicaid, she told me that she had been in Medicaid for a couple months a year ago. Not a year ago, a couple years ago. And sometimes she said it would give her trouble because it wouldn't cover as many colostomy bags as she wanted. So imagine you just have that colostomy bag there and all your stool is going into the colostomy bag and you want to change rather frequently, right? But she said that it would only cover a certain amount of colostomy bags a month, which would kind of annoy her because she didn't want to keep all the stool in that. So that's kind of where it could lack a little bit, but she also said that she had the same problem with some private health insurances and also in Medicare. So it's certainly not a problem just for Medicaid, but it's something that we must keep in mind as we move along. So now let's dive into what Medicaid actually looks like right now. And to better understand how it functions, we should first discuss how Medicaid funding actually works, because the funding of Medicaid is a very important part for us to understand how the partnership between states and the federal government works, and also to understand why people in different states may get different care. Because unlike Medicare, states can have different rules, and this is what we're going to discuss right now. So Medicaid operates as a unique partnership between the federal government and individual states. The federal government sets the overarching guidelines and requirements for the program, but it's up to the states to administer and implement Medicaid within their borders. This partnership allows for flexibility and customization to meet specific needs of each state's populations. At the national level, the Centers for Medicare and Medicaid Services, the CMS, a branch of the U.S. Department of Health and Human Services, oversees the whole Medicaid program. The CMS establishes the core rules and regulations that each state must follow, while also providing funding to support these Medicaid programs. This federal oversight ensures that certain standards are maintained throughout all states, and Medicaid operates in accordance with federal law. So now, here's where things gets interesting, right? Because while the federal government sets the broad parameters, each state have a lot of flexibility to design and operate their own Medicaid program within those guidelines. This means that Medicaid can vary from state to state in terms of eligibility criteria, covered services, and even the name of the program itself. States do their own handling of applications, they conduct eligibility assessments, and facilitate ongoing eligibility redeterminations. For example, one state may have broader eligibility requirements, allowing a greater number of individuals to qualify for Medicaid, and another state may have more limited eligibility criteria, resulting in a smaller population being eligible for the program. Another aspect where states have flexibility is in the covered services and benefits they offer to their Medicaid enrollees. And while they're mandatory services that all states must provide by the CMS, right? These are hospital care, physician visits, and prescription drugs. States can choose to offer additional services beyond these minimum requirements. These additional services can be dental care, vision care, physical therapy, and more. However, the availability of these services can vary greatly from state to state, meaning that beneficiaries in one state may have access to certain services that other beneficiaries in other states don't have access to. And states can also design their own Medicaid Managed Care Programs. Managed programs are not the easiest thing to understand, and I definitely didn't understand it the first time I heard about it. So I'll take a minute to explain what these are. Medicaid Managed Care Programs are a type of health insurance program that combines the financing and delivery of Medicaid benefits in a more organized way. Let's break it down into simpler terms, right? In traditional Medicaid, the government directly pays healthcare providers for the services delivered to Medicaid beneficiaries. But in Medicaid Managed Care Programs, things work a little different. The state contracts with managed care organizations, MCOs, which are private health insurance companies or healthcare providers that handle and coordinate the healthcare services for those enrolled in Medicaid. Here are a few important things to know about the Medicaid managed care. First, there are these managed care organizations, the MCOs, that partner with the state. They're responsible for managing and coordinating healthcare services for Medicaid beneficiaries within a specific area. When someone enrolls in Medicaid, they're assigned to a specific MCO within their designated service area. This means that the MCO takes on the responsibility of coordinating and providing all covered healthcare services for that person. MCOs have their own network of healthcare providers like doctors, hospitals, specialists, and pharmacies, and enrollees usually have to receive care from within the MCO's network. But there might be a few exceptions for certain out-of-network services, but usually you have to stay within that system of physicians and hospitals. To control costs, Medicaid Managed Care Programs often use strategies like prior authorization requirements, utilization management, and agreements with network providers on lower reimbursement rates. But keep in mind that they must follow all of the states and national Medicaid guidelines that we talked about earlier. And okay, so now that we understand the basis of how Medicaid works, let's talk a little bit more about the Affordable Care Act and Medicaid eligibility. And the reason that I want to talk about the Affordable Care Act here is because it really impacted Medicaid eligibility. So the Affordable Care Act was passed in 2010 under President Obama and played a significant role in Medicaid and its eligibility. So one of the key provisions of the Affordable Care Act was the expansion of Medicaid. This expansion sought to broaden eligibility criteria, allowing more low-income individuals and families to qualify for Medicaid coverage. Prior to the Affordable Care Act, Medicaid eligibility criteria varied significantly among states, resulting in disparities in access to care. And the ACA, the Affordable Care Act, aimed to provide a more uniform and inclusive approach by establishing a federal minimum standard for Medicaid eligibility that states could choose to adopt. And it proposed expanding Medicaid to include individuals with incomes up to 138% of the federal poverty level, providing coverage for millions of low-income adults who were previously ineligible. However, it's important to note that the Medicaid expansion under the Affordable Care Act was not mandatory for states. The Supreme Court's ruling in 2012 made the expansion optional, leaving it up for states to decide whether or not they wanted to expand their Medicaid programs. As a result, the implementation of Medicaid expansion has varied across states, leading to a patchwork of coverage across the country. And that's what a lot of the news has been about like Medicaid expansion, right? So states that chose to expand Medicaid experienced significant benefits, and expansion states saw increased in healthcare coverage, improved health outcomes, and reduced rates of uninsured individuals. The expansion helped bridge the coverage gap for many low-income adults who previously fell into the category of being uninsured but not eligible for the traditional Medicaid program. On the other hand, states that chose not to expand the Medicaid program left a portion of their low-income population without access to affordable healthcare coverage. Although this made it cheaper for these states, this coverage gap created challenges for individuals who were unable to afford private health insurance but did not meet the traditional Medicaid eligibility criteria. So, why haven't all states expanded to Medicaid, right? Well, reasons can vary. Some concerns raised include the potential for long-term costs for states and the complexities of implementing expansion. However, it's important to note that numerous studies have shown from state to state that have expanded Medicaid, and they indicate that the benefits far outweigh the challenges. And although we've been seeing more and more states adopt Medicaid expansion, and will hopefully continue to see more expand in the coming years, it's very hard to judge how long it will be until all states adopt Medicaid expansion, and if that will ever really happen, because it could be against some states' interests, right, if they don't want to spend that much money. So let's look at a quick example. We have State A and we have State B. In State A, Medicaid has been expanded under the Affordable Care Act. This means that individuals with slightly higher incomes may qualify for Medicaid coverage. The expanded eligibility criteria have resulted in significant increase in the number of low-income adults who can access Medicaid and state aid. This expansion has been praised for improving healthcare coverage to individuals who previously were uninsured. And it also led to improved health outcomes and financial security for many of the beneficiaries. Now let's turn our attention to State B. In State B, Medicaid has not been expanded. The eligibility criteria in State B are more restrictive, meaning that individuals with slightly higher incomes may not qualify and they may fall in that coverage gap. As a result, some low-income individuals in State B may fall in that coverage gap and they do not qualify for Medicaid, but also do not make enough money to buy their own health insurance or work in a place that provides health insurance for them. So this coverage gap can leave many individuals without access to essential healthcare services and lead to delayed or foregone care. Another aspect where State A and State B differ is their covered services and benefits. While both states must provide the mandatory services required by the federal government, State A has chosen to offer additional services beyond the minimum requirements. These additional services may include dental care, vision care, and mental health services. In contrast, State B, due to budgetary constraints and other considerations, has a more limited range of covered services. This state-level flexibility allows for innovation and responsiveness to local circumstances. However, it can also lead to disparities in coverage across the nation. So it means that someone in one state may have access to certain services or benefits that they may not have if they lived in another state. So it's important to note that the federal government provides funding to support state Medicaid programs. The federal government matches a percentage of the funds that states spend on Medicaid, with the specific matching rate varying based on states' per capita income. And we'll talk more about how they actually determine how much each state gets later. But now let's quickly discuss who's eligible to Medicaid from a federal level, right? Because we can't really discuss each state because every state is going to have their own set of guidelines. But let's discuss it at the federal level. What are the minimum requirements? And so our first group are low-income adults. And in states that have expanded under the Affordable Care Act, adults with incomes up to 138% of the federal poverty level may be eligible. And as of 2023, the annual federal poverty level for an individual is $14,580 per year, right? And for a married couple, it's $19,720. So if a state has expanded, it would be 138% of that, while if it hasn't, it would just be the federal poverty level. And keep in mind, those are the minimum requirements. If a state has expanded, the minimum requirement is that it be 138% of the federal poverty level. And if not, it's the values that I just explained, which is the federal poverty level. So next, let's talk about pregnant women. Medicaid recognizes that it's very important to provide prenatal care, and it often offers coverage for pregnant women with incomes below a certain threshold depending on each state. Medicaid actually covers 43% of all births in the U.S., and the average cost of medical care for a baby born without any complications is $4,550 in the first year, which is a lot, right? And keep in mind that the federal poverty level for an individual is $14,580. So $4,550 in the first year is a significant amount. And the average cost of medical care for a premature or low birth weight baby is $49,000 in the first year, which is just outrageous, right, if you don't have any coverage. And of course, we can't forget about the little ones. Children from low-income families are another key group that are eligible for Medicaid. The program provides comprehensive coverage for children up to 19 years old, with eligibility based on household income. In some cases, children from families with slightly higher incomes may qualify for the Children's Health Insurance Program, or CHIP, which bridges the gap between not meeting traditional Medicaid thresholds with those that are uninsured, right? Because there were a bunch of kids that were falling into the coverage gap, and the CHIP program came in to try to fix that. We'll talk more about the CHIP program because it's pretty significant in a little bit. But so let's just bring our focus back to who's eligible for Medicaid. And Medicaid also extends its support to elderly individuals and people with disabilities. And this category includes seniors who require long-term care services and individuals with disabilities who may need ongoing care and support. And the eligibility for this group is based on income and specific functional criteria to ensure that those who need the assistance the most can receive the care that they deserve, right? And additionally, Medicaid also offers coverage for categorical groups. This includes individuals receiving supplemental security income, SSI, certain refugees and immigrants, and those in need of family planning services. Each group has its own unique set of eligibility criteria to ensure that vulnerable populations can access the care they need, and this varies by state. So it's essential to note that while the federal government sets these general guidelines, each state has some flexibility in determining the exact income limits, categorical requirements, and eligibility rules. And now that we know who's eligible, let's better understand how the Medicaid program is actually funded, right? Well, Medicaid, as I said before, is a joint federal and state program, which means that both the federal government and individual states contribute to the funding. Now, you might be wondering, how does the federal government determine how much money to allocate to each state? Well, it's a little bit of a financial dance here. The federal government uses a matching system where they provide a certain percentage of funding known as the Federal Medical Assistance Percentage, FMAP, to each state based on their specific needs and resources. The FMAP is determined by a formula that takes into account each state's average per capita income compared to the national average. Essentially, states with lower average incomes receive a higher FMAP, meaning that they receive more federal funding to support their Medicaid programs. And on the other hand, states with higher average incomes receive a lower FMAP and therefore a smaller share of federal funding. So the FMAP is not a fixed number. It's going to vary between state and state and can change from year to year based on the economic conditions and other factors of that state. The federal government periodically adjusts the FMAP to reflect these changes and ensure that there's a fair distribution of funds between states. So let's go back to that financial dance that I mentioned earlier, because I want to illustrate how that actually works, right? So let's imagine two states again. We have state A and we have state B. State A has a lower average income compared to the national average, while state B has a higher average income. As a result, state A would receive a higher FMAP, meaning that they would receive a larger proportion of the federal funding to support their Medicaid program. Conversely, state B would receive a lower FMAP, reflecting their relatively higher income. And it's important to note that while the federal government provides a significant portion of the funding, individual states are also responsible for contributing their own share. This state contribution is often referred to as a state's matching funds. The specific matching rate can vary depending on the state's wealth and other factors, but generally it ranges from about 50% to 75% of the total Medicaid costs. So there you have it. Medicaid funding is a delicate dance between the federal government and the states, with the FMAP serving as the guiding rhythm. It ensures that federal funds are allocated based on each state's income levels and helps maintain the financial stability of the program. It's, of course, a lot more complicated than what we just discussed, but this is the general groundwork that it works from. But now that we discussed that, let's switch gears a little bit and go back to the CHIP program that I mentioned earlier, since it's a big part of Medicaid. So we'll delve into the Children's Health Insurance Program, better known as CHIP. So let's start with the burning question: why was CHIP created? Well, imagine a time when some low-income children were stuck in a healthcare coverage limbo. Their families earned too much to qualify for Medicaid, but not enough to afford private health insurance. These children were caught in the middle, facing limited access to essential healthcare services. Recognizing this critical gap, the United States took action, and in 1997, the Children's Health Insurance Program, or CHIP, was created. The primary goal of CHIP was to ensure that low-income children had access to the health care they needed, and it aimed to bridge the coverage and offer comprehensive health insurance specifically tailored to meet the unique needs of children. Now, you might be wondering, how does CHIP differ from Medicaid? CHIP offers a range of benefits including regular checkups, immunizations, prescriptions, dental care, and even mental health services specifically tailored to children. It offers affordable premiums and often minimal or no out-of-pocket expenses, making it more accessible for families facing economic challenges. But it's important to note that CHIP operates in a partnership with states, similar to Medicaid. The federal government provides the funding for each state to administer their own CHIP program. This flexibility allows states to tailor the programs to the specific needs of their population and the children that live in their state. And over the years, CHIP has become a key player in national children's healthcare coverage. So according to Medicaid.gov, I checked this earlier today, and as of February 2023, 93 million total individuals were enrolled in Medicaid, while 42 million of those individuals were children. And interestingly, the majority of children have Medicaid enrollment, and only 7 million are enrolled under CHIP. So that means that not that many children fall within that coverage gap, that they don't qualify for Medicaid, but they qualify for CHIP. But still, it's a very important program, because if it weren't for CHIP, the 7 million people would be uninsured. The 7 million children would be uninsured. So the results of CHIP were pretty quick. And from 1997 to 2012, the rate of uninsured children went down from 14% to a low of 7%. But it's interesting, because the truth is that many of these children that are still uninsured are eligible for either Medicaid or CHIP. A study by the Kaiser Foundation found that in 2021, there were 27.5 million non-elderly people uninsured. And out of those, 27.5% were eligible for Medicaid or CHIP. That's 7.4 million uninsured people in the U.S. that could be enrolled in free health insurance, but they just didn't. And out of that, 4.9 million are adults and 2.5 million are children. So there's still 2.5 million children in the U.S. That could be enrolled in either Medicaid or the CHIP program. Before we end the section on CHIP, let's just take a quick look on the role of the Affordable Care Act on children's coverage. So what does the Affordable Care Act bring to the table, right? Well, one of the crucial aspects is the requirement for states to align coverage for children. The Affordable Care Act mandated the transition of coverage for all children up to 133% of the federal poverty level from CHIP to Medicaid. So let's say you have all these children that are enrolled in CHIP because they didn't qualify for Medicaid, because before that, to qualify for Medicaid, the line was the 100% of the federal poverty level, right? So you had to fall within the federal poverty level. So all those children that didn't, they were in CHIP. However, the Affordable Care Act mandated that children up to 133% of the federal poverty level that were enrolled in CHIP now be enrolled in Medicaid. But that's not really all. The Affordable Care Act also focused on streamlining the enrollment process, making it easier for children and their families to access coverage. And they did this by simplifying and improving enrolling procedures. More families could then navigate the system with ease, and this ensured that more children who were eligible actually enrolled in the appropriate healthcare programs that they were eligible for. The Affordable Care Act also recognized the need for outreach effort for adults that could potentially indirectly impact the children's coverage, right? Because children are not the ones getting their own coverage, their parents are. So by increasing outreach initiatives to reach and enroll adults, more families became increasingly aware of the available healthcare options for their children. This comprehensive approach created a ripple effect, leading to increased enrollment and improved healthcare access for children. Now let's switch gears and talk about how Medicaid actually changed over the years. And here's a little bit more history for you guys, so I know it might be a little boring, but it's important to understand how it's changed and how it adapted to a changing population. So let's start with a significant milestone in the Medicaid program, the authorization of the Home and Community-Based Services, the HCBS waivers. Home and Community-Based Services waivers are a critical component of Medicaid that allows states to provide services to individuals who would otherwise require institutional care. These waivers began to be authorized under Medicaid in the 1980s, recognizing the importance of community-based care as an alternative to costly and restrictive institutional settings. By supporting individuals to receive care and support in their own homes or community-based settings, HCBS waivers promoted independence, improved quality of life, and often proved to be more cost-effective. For example, an HCBS waiver may enable an individual with a disability to receive personal care assistance and home modifications, allowing them to live independently and avoid unnecessary institutionalization. Because if you don't have to go to an institution, if you don't want to be institutionalized, now you didn't really have to, right? If you could get home services. which were now covered by Medicaid. So what this basically did is it began to cover certain in-home services for people that didn't necessarily have to be institutionalized. Next, let's talk about the Katie Beckett option. This was named after a young girl who faced challenges accessing Medicaid due to income limitations, and it was another significant milestone. This option allows states to extend coverage to children with disabilities living at home, even if their family income exceeds the typical Medicaid threshold. By recognizing the unique healthcare needs of children with disabilities, the Katie Beckett option ensures that they can access essential healthcare services without facing financial barriers. For instance, a child with a significant medical needs, such as a complex medical equipment or specialized therapies, can now receive medical coverage under the Katie Beckett option, regardless of their family's income. This has provided critical support for families who would otherwise struggle to afford necessary care for their children with disabilities. Next, let's talk about the introduction of Section 1115 waivers in 1990s that expanded Medicaid eligibility options. These waivers allowed states to experiment with different approaches to coverage and care delivery. So it basically allowed states to test out different eligibility criteria and care options that weren't normally required by federal statute, with a goal of finding better methods to do the system. So, for example, a state may use the Section 1115 waiver to extend Medicaid eligibility to individuals who may not traditionally qualify, such as low-income adults with dependent children. This flexibility empowers states to design programs that align with their unique population needs and kind of test out kind of like the scientific method. They can test out a bunch of different options and see what works best for them. And then after that, try to implement that, Then in 1990, something really important happened that changed the way Medicaid supports people with disabilities. It was a court case called Olmstead versus LC, and it had a big impact on home and community-based services. Let me break it down for you, right? There were two women named Lois Curtis and Elaine Wilson. I don't know if I pronounced the first one's name right, but her name was Lois Curtis. They had mental illnesses and developmental disabilities, and they were in a hospital for treatment. The doctors who were taking care of them said that they could be cared for just as well in a community-based program, but they were still kept in the hospital. So they decided to take their case to court because they didn't want to stay in the hospital. They wanted to be cared for at home in their own communities. And you know what? The Supreme Court made a landmark decision. They said that keeping people with disabilities isolated in certain institutions when they could live in the community is unfair and goes against the Americans with Disabilities Act, which is a law that protects the rights of people with disabilities, right? So this decision became a game changer because it meant that Medicaid had an important role to play in helping people transition from institutions to community settings. It also meant that Medicaid had to support community living for people with disabilities. Since then, we've seen a lot of progress in providing more opportunities for community living thanks to Medicaid. But here's the thing. The need for community services keeps growing, and many individuals who need these services still struggle to get them. So there's still a lot of work to be done to make sure that everyone can live in their community and get the support that they need. But Medicaid is continually finding new ways to help with community-based care and integration. So we're moving in the right direction. And finally, we arrive at the transformative moment that we already talked about, the Affordable Care Act, passed by President Obama in 2010. So make sure, if you guys don't remember it, go back to the section and listen to that again because I feel like I explained it pretty well there. But now that we've talked about all major topics related to Medicaid, I want to finish us off with some quick facts about Medicaid. So here they go. 1 in 5 Americans are covered by Medicaid. 93,876,834 Americans are covered by Medicaid, while 65,748,297 Americans are covered by Medicare, making Medicaid the largest source of health coverage in the U.S. In 2021, Medicaid accounted for 17% of the total national healthcare expenditure, while Medicare accounted for 21% of the total national healthcare expenditure. That is $900 billion for Medicare and $734 billion for Medicaid. It kind of makes sense that Medicare would cost more even though they have less people enrolled because all of those people are elderly and need a lot more care or they have very serious disabilities. or chronic illnesses, right? So, and keep in mind that in 2021, the healthcare expenditure accounted for 18.3% of the U.S. annual GDP. And this continues to rise every year. So if Medicaid accounts for 17% of that, 17% of 18.3% is 3.1%. Then Medicaid costs 3.1% of the annual GDP, specifically in 2021. Which, I mean, may sound small, right? It's only 3%, but keep in mind that this is 3% of the total market value produced in the U.S. in 2021. So, and that brings us to the end of our journey through the world of Medicaid. We've covered a lot of ground today exploring the history, purpose, and impact of this vital healthcare program. Let's take a quick moment to summarize everything that we've discussed. Medicaid was created in 1965 as a joint federal-state program to provide healthcare coverage to low-income individuals and families. It has evolved over the years to adapt to changing population needs, expanding eligibility criteria, and incorporating new initiatives to improve care and outcomes. We explored the challenges that Medicaid has faced, from funding constraints to variations in coverage and administration across different states. Despite these challenges, Medicaid has demonstrated its resilience and the ability to adapt to the needs of millions of Americans. We also discussed the Children's Health Insurance Program, CHIP, a crucial component of Medicaid that provides coverage to low-income children who don't qualify for traditional Medicaid but are unable to be insured through a family plan. CHIP helps bridge the gap for these children and ensures that they receive the care they need. Throughout our conversation, we debunked misconceptions and tackled some stigma associated with Medicaid. So we highlighted Medicaid's role in improving health outcomes, reducing financial barriers, and supporting individuals and their families in times of need. We explored how Medicaid coordinates care, addresses social determinants of health, and promotes health outcome. We examined the complex landscape of Medicaid, both at the national and state levels, discussing the funding mechanisms, eligibility criteria, and the role of federal government in allocating resources to each state. We also saw how states have implemented Medicaid differently, leading to variations in coverage and services. We also touched upon the Affordable Care Act and its impact on Medicaid, expanding coverage options, streamlining enrollment processes, and aligning coverage for children. The Affordable Care Act has been instrumental in driving progress and expanding access to healthcare for millions of Americans. And after all this progress, Medicaid is now the largest health insurance program in the United States. And that is it for today. I hope you learned a lot about Medicaid, and don't forget to join us again for part 2, where we will discuss the current events related to Medicaid, as well as talk to someone that has been on Medicaid to tell us about the ups and downs of their experiences. Thank you, and have a great day. Thank you for tuning in to this episode of the Gustavo Franco podcast. We hope our exploration of the world of healthcare has been insightful and thought-provoking for you. Remember, the opinions expressed here are ours and of our guests and should not be considered professional advice. This podcast is a collaborative learning experience for both the producers and listeners. While we strive to convey accurate and up-to-date information, we acknowledge that our research may have limitations. We encourage all of our listeners to supplement their knowledge by conducting their own research. If you enjoyed this episode and want to stay up to date on our future releases, make sure to subscribe or follow us on your preferred podcast platform and social media. We highly value your feedback, so please don't hesitate to reach out with your thoughts, questions, or suggestions for future topics. Thank you for joining us on this healthcare exploration. Together, we can foster a more educated America and contribute to a more effective healthcare future. Until next time, take care and stay informed.